the last time you or me or the people listening had a medical appointment, it probably cost money out of pocket. There was probably a gap to pay at the GPs. Maybe you needed to pay for pathology tests or scans, or there perhaps were specialist fees on top of that, depending on what your condition is. Australia is really lucky to have Medicare, which is our universal health scheme, and it allows public hospital care to be free and lots of services outside of hospital provided without out-of-pocket costs. But a new report has shown that there are big gaps in what's covered, and lots of people simply can't afford to cover the difference. And of course, that means it's the poorest and the sickest, the people who need the most healthcare, who miss out on the most. So Stephen Duckett is one of the authors of this report from the Grattan Institute, and he joins us now. Hi, Stephen.
Hi, Tegan.
Where does the cost lie when we're looking at out-of-pocket healthcare?
So across the board, really, in our report, we looked at medical services and pharmaceutical benefit scheme prescriptions, and there's a lot of the out-of-pockets fall there. But there's also out-of-pockets in private hospitals. There are out-of-pockets in non-pharmaceutical benefit scheme prescriptions, so over-the-counter. There's allied health. So there's right across the board. And surprisingly, Australia has a very high proportion of our healthcare met by out-of-pockets relative to other countries, and we spend more on out-of-pockets in Australia per capita than the United States does.
Wow. So your report has sort of detailed this and also made some recommendations on how we could improve this to improve people's access to care. What are some of your biggest top-line recommendations?
Well, as I said, there are lots of areas where out-of-pockets occur. We looked at medical specialists, and if in contrast to a GP, about 90% of GP services are bulk billed, but only about 48% or so of medical specialist attendances out of hospital are bulk billed. And so we said one of the things to fix up is this medical specialist scene. And, for example, we said there are a couple of ways of doing it, a number of ways we can do it, and we should do all of them. So the state government should step up and provide more public hospital outpatients, and we suggest an expansion in that. And there's also room to improve efficiency by improving the number of new patients relative to review patients. We also said the Commonwealth Government should step up and provide bulk billing clinics so that in low-income areas with low rates of bulk billing, we actually provide a private alternative which means that specialty care would be more accessible.
Right, so these clinics are specialist clinics that are also bulk billing.
Yes.
I mean, these things don't come for free, but then I suppose neither do long-term health conditions. Like, what's the equation here between what you're asking governments to spend and what potentially people are spending down the track if these prolonged conditions aren't treated in a timely way?
Yeah, so there are two ways of looking at it. In the short term, what we recommended was about 700 million or so of additional government expenditure, and in return you'd save $1 billion or so of out-of-pocket. So instead of consumers paying, the government would pay. Importantly, this is a benefit in health terms as well, because each of the areas we looked at was where a doctor had recommended the patient do something, where the doctor wrote a prescription, where the doctor recommended the patient have an X-ray, where the doctor recommended the patient see a medical specialist.
Right, so it's almost like the doctor's the customer, not the person who's gone for an appointment.
Exactly. And then it's crazy to say, well, there has been medical decision that this is necessary, and then the poor old patient can't afford it, and so there's obviously going to be a subsequent cost because of delayed care or the situation getting worse or whatever. And so it's in everybody's interest, the patient's interest, the taxpayer's interest, everybody's interest, to actually try and get rid of these barriers to this secondary sort of care that we're talking about.
Right, there's this financial incentive to not follow your doctor's advice. But for the Federal Health Department put out a statement today saying that Medicare bulk billing has reached a record high in the last quarter of 2021. Like you said before, this statistic of almost 9 out of 10 GP visits were bulk billed, and they say that essential medical care is more affordable than ever. So how does this gel with what you found?
Well, of course, their job is to say, the Commonwealth Minister's job is to say things are going well. That doesn't mean to say they can't get better. And the Minister is right. almost 90% of GP services are bulk billed. About 2/3 of all Australians who go to the doctor have all of their GP services bulk billed. But that's not what we're talking about. What we're talking about is medical specialists. What we're talking about is prescriptions. What we're talking about is allied health. So the minister is actually not talking about what we're talking about. He's talking about an area where, by and large, the system is working really well. We're talking about the part of the system which isn't working well, which needs to be improved, and we need to turn our attention to it.
So you mentioned two things there, allied health and prescriptions. Can we talk about those a bit? What changes would you like to see there?
Well, again, we have a very good pharmaceutical benefit scheme. The medicines are basically affordable, but if you're with chronic condition, for example, you're going to use lots of medications, and the costs add up. And although there's a safety net for prescriptions, that for a person who's not a healthcare card holder, it cuts in at $1,500. And that's a lot of money that not everybody has. And so what we're saying is there are a couple of things that can be done about that. First of all, if you've got a chronic condition, there's no particular reason why the standard prescription couldn't be, instead of a 1 month supply, couldn't be for 2 months supply. So you actually have less number of times you actually have to go to the chemist to pay the co-payment. So we change the way we write prescriptions. Another thing we could do is say, look, if you're on a lot of medications, you might have had a number of doctors put you on those medications, and there might be some contraindications for those. So why don't we have a scheme where the computer analyses what's happening and whether there might be contraindications, and then alerts the doctor, and the doctor then says, let's do a medication review for this patient, and if all of those medications are still needed, then the patient should be able to drop down to a lower co-payment so they can afford what are now pretty clearly necessary medications.
And it's not just about money when it comes to multiple medications. We've talked about the problems of polypharmacy on this show before. Really briefly, Stephen, if only one of your recommendations was taken on board, what would it be? What should it be?
Well, I think in the first instance for government to acknowledge there is a problem. And so just to say, yes, we know Medicare's good, we need to make it better. But I think the one that's most important is not the most expensive one, but is actually moving to have bulk billing clinics around the place and providing more information to GPs about what the fees are that doctors are charging.
Stephen, thanks so much for joining us.
A pleasure, Tegan.
Dr. Stephen Duckett is Health and Aged Program Director at the Grattan Institute.